Good afternoon, everybody. Thank you for taking the time to join the Nigerian Society of Travel Medicine's webinar. This is the Travel Post-COVID-19 Lockdown, What to Expect, Preparing Returning Students for Travel. We're just going to give people about a minute or two to join, so please hold on and we'll start soon. Thank you. Good afternoon, everybody. We're just going to go ahead and start now. So thank you everyone again for taking the time to be here. Like I said earlier, this is the webinar by the Nigerian Society of Travel Medicine, guiding the profession and protecting the traveling public. We are all here for the Travel Post-COVID-19 Lockdown webinar, what to expect and preparing and returning students for travel. Today is June 17th. 2020, and it's a little bit after 2 p.m. West African time. So good day, and thank you for taking your time to be here. It's no longer news that we are currently going through unprecedented times, and our world, as we know, is changing gradually. We want to let you know that the Nigerian Society of Travel Medicine is thinking about you at this time. As our lives have been impacted by COVID-19, there is a need to modify some of the ways in which we have lived our lives pre-COVID and find new ways to live better and safer. And to this effect, the Nigerian Society of Travel Medicine will be hosting a series of webinars that we hope will inform, motivate, and guide you, starting with today's webinar, the Travel Post-COVID-19 Lockdown. So quickly, the Nigerian Society of Travel Medicine, like I stated earlier, we aim to guide and promote the development and practice of travel medicine across the country in collaboration with appropriate local international bodies. So we're going to go ahead and start. I'm going to go ahead and introduce the first speaker. The first speaker is Professor Visser. I'm going to go ahead and he's going to talk about the first presentation. He's going to go ahead with the first presentation. 1 second, please, while I introduce him.
Oops.
So, Leo Visser?
Yes.
So, I would like to tell you a little bit about Professor Leo Visser. He is the professor of infectious disease with a specific interest in travel medicine, and is the immediate past president of the International Society for Travel Medicine. Leo is the head of Department of Infectious Disease and is the Deputy Director of Internal Medicine Residency Program at the Leiden University Medical Center. Leo Visser is a member of the European Expert Committee on Travel Medicine. So take it away.
Well, thank you very much for the invitation. I see that we have 90 participants already, so this is really amazing. So I will start, and I will share my screen. First, I'll do that. And this one. Yes, share. And then, so please let me know if it projects well.
Yeah, we can see all your slides.
Perfect. So I would like to give an introduction on the clinical disease of COVID-19 and how its epidemiology developed over the last half year, I would say almost, and the effect on travel. And but the main focus will be on the disease and its characteristics. And I think one of the first characteristics is actually that the COVID-19 pandemic is acting like a kind of magnifying glass, and it really shows the shortcomings of the fabric of our society. And you can see that those people that are most vulnerable suffer most from this outbreak everywhere in the world. What you see here is a people from Mexico, where at the moment the COVID pandemic is actually on its peak, and the healthcare structure is collapsing, and as a result, many people die, and mass graves are dug where people take and mourn about their loved ones. So, in a nutshell, actually SARS-CoV is a kind of lethal mix, I would say, of the transmissibility of a common coronavirus with the lethality of SARS-CoV-1 or MERS-CoV. So it gives an upper respiratory tract infection in most cases, just like the human coronavirus does, and as we know it as common cold viruses. But in a small group of people, and especially the vulnerable people, it induces a lower respiratory tract infection, and at that point it can cause severe disease and respiratory failure and death as a result. And because it's a pandemic, this actually means that nobody is protected worldwide, and everybody can get the disease within a very short window of time, which results in overwhelming the health structure, because then, of course, even if it's a small percentage, if the whole population gets ill, it becomes a massive number of people that require, for example, mechanical ventilation. So if we go and have a look at the virus, so coronavirus, it's very important to know that the throat and the lung is actually the area where it's the ground base where they will attach. But many other cells in the body have AC2 receptors, which is the part which binds to the spike of the virus. So AC2 receptors are also present in the heart, in the brain, in the kidney, in the gut, and so you can expect also that other organs, apart from the upper respiratory tract and lungs, can be affected. The second important part is that once it binds to, the spike binds to the AC2, it's spliced, and it uses human enzymes for that, furin, but also a TMPRSS2. And especially the last protein is a protein which is under the influence of androgen. So you can imagine that when you have a lot of testosterone, you have maybe more TPRSS2. As a result, this may explain why males are more susceptible than females to an infection with SARS-CoV-2. After the splicing, fusion peptides are expressed, and this will allow the virus to enter the cell that is carrying the AC2 receptor. And then it is important to know that before the typical symptoms start, which include fever, cough, and shortness of breath, people may already have some atypical symptoms, which are, for example, malaise or just a nasal congestion, some myalgia or some nausea and diarrhea. And during that phase already, people are excreting lots of virus that is viable and so infectious to other people. And in this particular study from the US, in a healthcare facility, they cultured people on several days, and you could see that 6 days before the typical symptoms until 9 days after the typical symptoms, people carried and were excreting, shedding infectious virus. And especially in the beginning of the disease, so really very shortly after that the symptoms start, the peak of the viral copies is at the highest, so then you can expect up to 700 million copies per swab. And so people are most infectious at the beginning of their disease, and during the first week, let's say the viremia or the viral load goes down. The cultures become negative, although the PCR can still be positive up to 2 weeks. After about 8 days, the cultures become negative. And so the idea is that about 8 days after start of infection, people are no longer infectious unless they come from an ICU department. And at that time, between day 7 and day 10, seroconversion occurs, and most people are seroconverted at day 14 after infection. So it's important to remember that the people before, actually at the very beginning already, when they have very atypical symptoms, they are have high levels of viable virus, and that's the phase in which transmission for example, in a household contact, can easily take place. The transmission is caused by droplet infection, and as we speak, sing or shout, we produce small droplets which will be projected into the air, and that's why the physical distancing is one of the measures where you try to reduce exposure to those droplets. Because of their weight, they will fall, and so normally they won't travel much more than 1 to 2 meters. And so that's the reason why the physical distancing has a distance of 1 to 2 meters. Those droplets contain viable virus which comes on the surface, and also the surface which has the droplets can still be infectious for some time, and especially parts of the house that are touched very frequently, or in a hotel or in public transport. The parts that are touched very frequently by many people are most likely to be the source of infection. And when you then touch your hands to your face, you can inoculate yourself with the virus. So if you look at the symptoms, so the incubation time is about 4 to 5 to 6 days, and then the symptoms the typical symptoms can occur. And one of those very findings which arose during a tracking app users. They found that loss of smell and loss of taste was also one of the symptoms of the SARS-CoV of COVID-19, apart from the cough or shortness of breath. People can complain about loss of smell, and it can occur up to about 1 in 3, so it's quite a frequent complaint. And so if somebody is complaining of that, you have to be suspicious that it is a COVID-19 infection. Only a minority of the people, the infection then actually travels to the lungs. And for example, microaspiration could be a cause, and when one becomes older, microaspiration occurs more frequently, so this may explain why older people have more frequent lung problems. Also, when you are, and that's more for the medical profession, when you are creating aerosols, for example, by using nebulizers, then you actually create very small droplets that you can inhale. And if you are not wearing PPE, you can actually inhale that into your lungs and become infected that way. Also, singing and taking deep breath during the singing can cause pulmonary infection. And then again, in the lung, in the alveoli, you have the pneumocytes that carry the ACE2 receptor, which can, and so those cells can be infected. And then this causes about at day 7, between day 7 and day 10, an intense inflammatory response because of the influx of T cells and of macrophages, and this can cause what we call a cytokine release storm, in which several interleukins play a role, like for example IL-6 and IL-1, and so some of the therapies that are trialed at the moment are directed against those interleukins. So in the beginning, so at day 3, that's on the left-hand side, you have this kind of typical ground glass lesions, which then can evolve to the more patchy and consolidations you see on the right-hand side. This is about day 7. And so when the patient deteriorates between day 7 and day 10, up to, 85, even 90% of the lung tissue can be involved. And you can imagine that people at that point have a lot of difficulty of oxygenating their blood. And actually, it's a hypoxia disease, so it has very similar symptoms as high altitude disease. That means that people do not feel dyspneic, but they are tachypneic. They have a respiratory rate up to 40, and they are not very well aware of their hypoxia, and that makes it a very tricky disease in the sense that at a certain point they get exhausted, and then the hypoxia becomes so intense that they can rapidly, within half an hour to an hour, become a patient that needs to go to the ICU. And these patients, another phenomena occurs, and that's that also the endothelial cells can be infected by the SARS-CoV virus, as you can see in the picture on the left-hand side. So you see the small green circles also in the endothelial cells, and this causes coagulation or activates coagulation. And what has been, especially in the very severely ill patients, you see thrombi in the microvascular system of the lung. And this is shown on the right-hand side. There's a 3D rendering where you can actually see that the capillaries in the lungs are completely filled with a fibrin cloth. And this adds to the difficulty in oxygenation because of the inflammatory response. And many people on ICU have pulmonary embolisms. So this is an extra or an additional cause why people, despite being on a ventilator, can progress to more and more severe disease and finally die on the ventilator. This picture this slide is quite busy, but you have to look at the bottom, and it shows you the case fatality ratio. And it is very clear that age is a very important predictor. I must say these are the data that come from Asia and from Europe, and we have no data yet from Latin America and from Africa. So it might be that it may be somewhat different depending on the continent where we get the information from. But it's very clear that over the age of 60, the outcome, the case fatality ratio, is really worse than below the age of 60. And the older you become, the worse the outcome is. So also, very young people have a very low case fatality ratio. But again, if 100,000 of children are infected, there will be a number of children that have severe disease and can die from it. It really depends on the numbers, but as you can see, the percentage is very, very small. Apart from age and gender, so males are more likely to be, this is a picture showing the patients on an ICU. So it's, again, old age, as you can see in the y-axis, people are older than and also there are more males than females. But on the y-axis, you can see the BMI. So obese people tend to be younger and also on the ICU. And this is a phenomenon that was observed especially in the US, where many young people with with obesity were admitted to the ICU because of severe disease. And the idea, I'll come back to that later, why that is. So that's here in this slide, because there are probably several reasons why age and cardiovascular morbidity and obesity play a role. So first of all, you have an impairment of the cytosolic interferon signaling in response to the virus. So the older you become, the less well your innate response will be, and therefore the virus can replicate more easily. Secondly, we have, when we become older, less naive B cells. So that means that the buildup of antibodies is slower and less well developed. Thirdly, our endothelial system has a higher rate already baseline inflammation because of cardiovascular morbidity and obesity, and therefore the infection adds to that. And finally, one of the hypotheses why children in general are more protected is that maybe they are cross-protected because they have had the common cold viruses, coronaviruses, much more recently, and therefore they have cross-reactive T-cell recognition that partly protects them against SARS-CoV. So there are several reasons why children are less susceptible. They have a better interferon response. They have more B cells. They have less or no cardiovascular comorbidity. And possibly they also have cross-reactive T cells that protect them more against SARS-CoV. There were some promising indications for therapy like chloroquine and remdesivir, which you show on the left-hand side. You can see a dose-response curve for chloroquine and remdesivir. This is all in vitro studies, so there were, it turned out that chloroquine is actually very disappointing, and the last big study that was performed in the UK actually shows that it does not have any influence on the outcome. So hydroxychloroquine nor chloroquine has any influence on the outcome of SARS-CoV infection. That is no longer advised to take. And remdesivir, it's also a big discussion whether this is a giant step forwards or just a tiptoe. This slide shows you the results of a compassionate use study, which is uncontrolled and which shows improvement in patients receiving remdesivir. But as I said, there is no control. So it is unclear how, to what benefit or how effective remdesivir actually is. And I think Gilead has done a poor job in designing the right trial. They probably were as surprised by the epidemic as many of us were. Yesterday, it was all in the news in Europe. I'm not sure whether it's already in the news in Nigeria, but a very large study in the UK, the recovery study, demonstrated that the use of dexamethasone in a low dose of 6 milligrams a day, especially in patients that are going to on the ventilator, can be life-saving according to the first reports on the news. I must say I haven't seen the results yet, so if it is really confirmed and the results are convincing, then this is actually a drug that is widely available and can actually prevent people from getting on the ventilator and prevent people from dying when they are on the ventilator. And it's low cost in contrast to many of the interleukins inhibitors that we are trialing at the moment. So this is something to look out for, to look at the first publication on dexamethasone, because this is something that might be useful in many parts of the world. So knowing now the characteristics of the virus, we know now that it actually in more than 89% of infections, it's mild or has very low symptoms. And that means that most of the patients will not seek healthcare, will not receive a diagnosis, and will spread the virus to their contacts. And only a fraction has severe disease or fatal disease. And it's especially the vulnerable people that are older, have comorbidity, that actually are at risk. And so this explains why this infection has become a pandemic. So for that, we have to go back to Wuhan, an industrial city of 17 million inhabitants. And if we go back in December and we look at the mutation rate, which is shown on the part on the left-hand side, if we take the mutation rate into account, it's very likely, and that's in orange, that the epidemic actually already started at the beginning of November, because we know the new mutation rate. We know if we sequence the virus, we can actually back calculate the time of occurrence when it started to occur. And so estimates are that actually the epidemic started around the beginning of November and was only detected at the end of December. So that means that if you take a basic reproductive rate of 2.5 into account, that at the time it was diagnosed or actually signaled, and that's on the right-hand side, we already had 150,000 people that were infected at that point. So you can imagine that you only had the tip of the iceberg that was diagnosed, and you had already a very large part of the population that was spreading the disease. And Wuhan is a capital city, but also it's the central of the high-speed rail map, as you can see. So it's well connected with many cities within China, and it's also an international hub for air travel. And therefore, Wuhan was perfect situated to export the disease to the remaining parts of China and to the world. And that's shown in this slide. So what happened was that in January 23rd, the air travel was actually blocked from Wuhan. But then at that point, the infection already spread to many other areas of China. And that is shown on the left-hand side on the lower part, where you can see large city in China from where out the infection could travel to other countries of the world. So the travel reduction, even if it is up to 90%, if it is not accompanied with any other reduction of transmission, for example, physical distancing, home isolation, and even lockdown, it really has no effect on the transmission and so it and on the spread over the world. And that's actually what has happened. So at the point when the outbreak was detected in Wuhan, we already had more than 150,000 people infected. Many of those had traveled to other cities in China, and many of those had infected other people that already traveled by airplane to the rest of the world. Also, airport screening, looking at temperature, does not really work. And as we already told before, most of the people will not develop any symptoms, so mild symptoms or no fever. So that could be up to 25 to 50% is subclinical. So that would mean that we would miss, at least 50 to maybe 70% of the infected people if we just screen them on temperature. So airport screening is ineffective in preventing the spread of the infection. And therefore, the outbreak actually was able to spread from China to the neighboring countries. And then we had a second very large outbreak in Europe, where it was mainly Spain, France, and Italy, from where it went to other parts and also to Africa, actually. Europe was then the center from where it spread to other countries. And at the moment, the outbreak is moving from US.
Leo, can you unmute yourself, please? Leo, can you hear me? Yes. Yes, thank you. Go ahead. And
I'm not able to go back, but that's okay.
Yeah.
The point I wanted to make in the last slide was that actually Africa, the doubling time of the epidemic was from the first 100,000 cases was in the beginning. I can't remember the number exactly. Just a moment, I can tell you. The doubling time was first doubling time, so from the first case to the first 100,000 was 98 days, but from the second 100,000 to the second 200,000 people, that's in only 18 days. So of course, there's much more testing done at the moment in Africa, but it looks as if the epidemic is actually increasing at the moment in several African countries. And the only approach we currently have is our behavioral approaches. So what we do is actually physical distancing, and the effect of physical distancing is shown in this graph, where you can see that if you prevent people from transmitting the disease to other persons that actually this has a profound effect on the amount of people that are infected in the end. I don't understand. Just after this works. So that's one of the reasons why in Europe, in many countries, we went to a complete lockdown. So in the upper part, you can see the effect of the lockdown in Italy on the reproductive rate, where it dropped from about 3.5 to around 1 at the moment that it was complete lockdown. In Sweden, that's the lower part, there is no complete lockdown, and they are still having increasing numbers. So there is a big discussion actually at the moment in Sweden on how to reduce the numbers. So the lockdown actually comes with an enormous economical and social price, and in many countries, like here in India, a lockdown was installed for a few weeks, but then it was actually unsustainable, because the most vulnerable people would die from hunger. And so the country is opening up again at a moment where the epidemic is still actually increasing. So this is going to have a profound effect on the number of cases. But in India and in many other countries, it's a kind of catch-22 situation. It's economically and socially not feasible to have a lockdown on one hand. On the other hand, the epidemic is actually still spreading. And in these situations, the WHO will advise to use masks, face masks, to try to reduce part of the transmission in situations where physical distancing is impossible. In other countries, the political leaders try to ignore the outbreak, like in Brazil. And also this again will affect mostly the poor people that are unable to comply to any physical distancing. So a final slide would be on the travel. So at the point that, so most countries had a complete shutdown of their international air travel. And it is estimated that there will be a reduction of 1.5 billion travelers by international air travel this year. And so the reduction in air travel will be around -50 to -70%. On the right-hand side, or the left-hand side, you see the carbon dioxide emission as a consequence of the lockdown in several areas. And this is in power generation, in the industry, in surface transport, and in pink, the aviation. And you see surface transport and aviation has dropped almost to zero in many areas, and that had a profound effect in the carbon dioxide emission. What you see in Europe is that countries with similar epidemical situation, that actually the connection between those countries is starting up. So we have air travel that is linking countries with similar epidemiological situation. And this is probably something that the next speakers will talk more detail. But air travel is probably going to start up in this way again. So to conclude, the COVID-19 pandemic magnifies the shortcomings in many of our societies. It especially affects those who of the population that is already suffering hardship and poverty. It is a mix of a common cold virus. When it gets to the lung, it can cause a lethal pneumonia. Most people are actually have mild symptoms and are able to spread the disease. And at this moment, the epidemic is moving from South America, and potentially it's now starting up in Africa. Thank you for your attention.
Thank you very much, Professor Leo Visser, for taking the time to go through this with us. That was very enlightening. Does anybody have any questions? We're just going to be able to take one question in the interest of time. That was an overview of the COVID-19 pandemic. And we just want to take one question before we move forward to the next speaker. Anybody with any question? Just raise your hand using the buttons below, or the buttons on your screen. If there's no question, we can take the question at the end of the webinar.